Okay.
Okay. Thank you all for thank you all the attendees for accepting our invitation as a biologics to attend this meeting entitled Bone Diseases and Skeletal Dysplasia focusing on HPP, Diagnostic and Management Consideration. Thanks for Dr. Ilham to moderate this session. Please, Dr. Ilham, proceed with the invitation.
Thank you very much. Hello, everyone, and welcome to this webinar. I'm Dr. Ilham Atiq, a pediatrician. It's my pleasure to moderate this important webinar, which highlights the diagnosis and management of hypophosphatasia. Without any further delay, it's my great honor to introduce Dr. Hussein Al-Saffar. Dr. Hussein Al-Saffar is a pediatric endocrinologist consultant at Sultan Qaboos University Hospital. He was the clinical lead of pediatric endocrine and diabetes services at Mid-Cheshire Hospitals NHS Foundation Trust. He had taken several roles before moving to Muscat, like Honorary Post-CCT Fellow, Secretary of Mercy, Pediatric Endocrinology Group. In his first year as a consultant, he was accredited to be an educational supervisor. Dr. Al-Saffar was the co-author of a chapter about hypothalamus pituitary axis in a reference textbook of pediatric endocrinology. Dr. Al-Saffar is the Deputy Chair of Communication Committee at the Arab Society of Pediatric Endocrinology and Diabetes, ASPED, and the Communication Committee member for the European Society of Pediatric Endocrinology, ESPE, leading a project of providing patient educational material in different languages. Recently, he became an honorary associated professor for the University of Wasat. I'm sure that his CV is much more than this, but just to keep it short. So welcome, Dr. Hussein. We would love to hear from you. The floor is yours.
Thank you very much for such kind introduction from you. And thank you very much for the invitation to be with you in this webinar. So we're going to have, I hope, an interesting 45 minutes where we're going to discuss an important subject. Yet it's a bit rare, but it's very important disease because it has lots of implication on the life of affected people. So let me share my slides with you. So do you see my slides? Are they clear to you guys?
Yes, please proceed, Dr. Hussein.
Perfect, thank you very much. Let me just minimize all these things. Great. Perfect. So let's go through this. These are my disclosures. And the outline of tonight's subject will be starting with presenting a few cases. Then we'll go through the pathophysiology of hypophosphatasia. How can we diagnose it and how can we treat? What are the options that we have? Right, so let's start with the case one. Case one is a 7-year-old female presented with a history of short stature and fatigue. That's the reason for referral to see the pediatric endocrinologist. She had recently contracted a streptococcal infection that led to a pneumonia, and she was treated with antibiotics, and then she's just recovering over the last few weeks before she got this referral. Past medical history, she walked independently at age of 2 years, a little bit late, and she had non-traumatic tooth loss at age of 3 years. That is also a little bit early. Usually the kids, they will lose their milk teeth or baby teeth at age of 6 years. But in this case, the tooth fell off at age of 3 years. These are her percentile charts. She seems to be that she's growing for height and weight on the lowest centile for normal. Okay. It seems to be that since beginning, started with the lowest centile and she's just following that. Doesn't seem that she crosses centiles or dropping or flattening growth, but yet she's been referred due to her short stature and fatigue. On examination, she's got mild knocked knees, and the rest of the examination is unremarkable. And these are her labs. So let's go through the labs together. Her celiac screen was negative. The full blood count was normal. Thyroid function was normal. Renal profile normal. ALT, liver enzymes, that's the ALT 28, the AST 30. You have the reference values here between brackets, the normal reference values. The albumin 38 to 54 gram per liter. The alkaline phosphatase 55, vitamin D 45, calcium 2.56 millimole per liter. The within normal. Phosphate 1.9. So the first question is, what is the most likely diagnosis based on just these information that we have just received? Is that just normal child? Could this be hypophosphatasia? Could this be osteogenesis imperfecta? Could be rickets? Or you would say, I'm unable to diagnose, I need further investigation, further information. So unfortunately, we don't have a poll here, but I will take your answers in the chat box. So if you put A or B or C, D, E, whatever you think is appropriate according to that. Okay, so see the first answer is possibly B. Let's wait for the rest. E, unable to diagnose, we need further investigations. Yeah. Any more? We have only two answers so far. B, thinking could be hypophosphatasia. Okay, so right, so let's move on. We'll move to the second case. Now, this second case is a 14-month-old female. She presented with history of cough started for 5 days, associated with fever and shortness of breath. Examination, I will talk about that in a second, but she's got a past medical history of recurrent chest infections. So this is not the first episode. And she's got previous assessment by the physician, the general physician, who said that she looks a little bit floppy. And she's got abnormal movements as well. It started at the age of 3 months, and now she's 14 months. And this patient was born at term by normal vaginal delivery. The parents are healthy. They are related to each other before marriage. They're consanguineous. They have 2 other healthy children, and the family history had 1 spontaneous abortion. On the appearance, as you could see here, it seems to be there is a rachitic rosary there, and these are cautery marks. This case was reported by Dr. Roba Abu Isa from Saudi Arabia. And in the Middle East, they got this kind of traditions of using, you know, the what they call it, wasin. Basically, they burn the skin of the area they think the problem is arising from. So because this child's got a recurrent chest infection, so they burned her lower half of the chest, thinking they are going to treat her problem. So she's got rachitic rosary, as we said there, and these are the cautery marks. And she appears having a bulging anterior fontanelle, cone shaped, and she's got small head. Okay. And examination-wise, revealed that she's got global developmental delay. Actually, her developmental age is around 3 months, and she's got delayed teething. Got severe respiratory distress at the time. Her growth parameters showing that she's failing to thrive. With that microcephaly that you've just seen, it was wide, bulging anterior fontanelle and open posterior fontanelle. There's a frontal busing and there's a head lag going with the hypotonia. And she's got hyperreflexia on examination without clonus. Here are some of the investigations. The blood gas was normal. Full blood count normal, thyroid function, renal profile normal. The enzymes here, the ALT 28, AST 30, parathyroid hormone 3, alkaline phosphatase 14 markedly reduced, 125 vitamin D is low, calcium slightly on the higher side, and phosphate is a little bit high as well. So the question here, which of the following investigations would you like to perform? Would you like to do MRI brain, or would you like to do EEG, or would you like to do kidney ultrasound, or you prefer a skeletal survey, or in fact all of these investigations you think they are warranted? So let's go back to the chat box and let's see, what do you think? Right, so see, people are thinking more towards skeletal survey. Yeah. Right. Yep. Any other answers? Right. So in fact, in this case, all of these investigations were performed. The MRI brain, because this child has got microcephaly with that shape, the cone shape of the head, with the wide and bulging anterior fontanelle. So they wanted to see what is going on from anatomical point of view, to study if there is any brain pathology. EEG was arranged as well for the abnormal movement that she was having. Kidney ultrasound because she's got hypercalcemia and wanted to know if that hypercalcemia is causing any problems with the kidneys. And of course, skeletal survey because of that low alkaline phosphatase, okay, significant low alkaline phosphatase. So therefore, they did all these investigations. Right, let's review the labs now for both cases. So the first case was a 7-year-old and the second case was 14-month-old. The abnormality, the clear outstanding abnormality here was about the alkaline phosphatase. So in the second case, it was clearly low, 14, whereas the lower limit normal is 150. The first case, the alkaline phosphatase was 55. However, the normal values written here is 40 to 150. Now, the question is, we know that in a younger age group, the kids usually will have higher alkaline phosphatase compared to adulthood. So they start with the requirement of having high alkaline phosphatase in the first few years of life, and then will go down and settle at a lower level during end of adolescence and the start of adulthood. So 40 here as a lower normal range sounds a little bit odd for a 7-year-old child. A 7-year-old child is supposed to be growing, therefore you would expect the alkaline phosphatase to be active and the level will be higher. So it seems to be there's something wrong with the reference range here. And in this lab, they were not using the appropriate alkaline phosphatase ranges for gender and age. They put 40 to 150, which is the adult ranges, not for a female child aged 7 years old. So it wasn't flagged up as abnormal alkaline phosphatase in the first place. And then look at the calcium. The calcium was normal in this case, a high normal, while in the second case was high. It is elevated. It is hypercalcemia in this case. Right. So just keep those in mind. I will move to third case, a last case, and then let's explain what's going on in these cases. Now, this case is a 4-month-old boy presented with seizure, and that seizure was refractory to all anti-epileptic medications. And then because this child was seizing, lots of investigations took place, including the bone profile, which shows there is a hypercalcemia. Right? Past medical history, again, recurrent chest infections. This child is hypotonic, having abnormal movements, which started at the age of 3 months. Right? This child, no, sorry, it even started actually on the 3rd day of life. He is a 5th child to parents who were first cousin. The child was born at 36 weeks gestation, spontaneous vaginal delivery, and the birth weight was 3 kilograms. He was discharged from hospital on the second day of life, and then he returned on day 3. So the abnormal movement started on day 3, in fact. A very extensive history here. Started having abnormal movement on day 3 with generalized tonic-clonic seizures. Somehow he ended up having EEG quite early on life. That's a little bit unusual. Anyway, it showed abnormal spikes. He was started on anti-epileptic medication, phenobarbital and phenytoin. They controlled the tonic-clonic seizures. However, the myoclonic convulsions continued as appearing as bouts of crying, and the child seems to be restless. EEG at 2 months showed hypserethnia. Therefore, synacthin and valproic acids were added to the anti-epileptic medications. But 2 days later, the baby developed involuntary movement of the extremities, and he was found to be hypercalcemic. So now at 2 months of age, he's already taken a number of anti-epileptic medications, and then he found to be hypercalcemic. Now, when he was found to be hypercalcemic, a decision was made to stop the phenytoin and valproic acid, as well as synacthin, and clonazepam was added later on. But the abnormal movements continued. Examination, the child was failing to thrive, generalized muscle hypotonia, again bulging fontanelle, and you can see here that he's got short bowed lower extremities. The blood investigations showing very low alkaline phosphatase, as you've seen here. The parathyroid hormone was low. The calcium was elevated, markedly elevated, 3.64. Okay, and the phosphate was in the upper normal range. Now, this high calcium is worrying, isn't it? It is worrying. The question is, how would you treat the hypercalcemia? Would you continue with the IV hydration that the child was on, but you may double the amount of fluids and you add diuretics? Or would you give bisphosphonate to lower the calcium? Or you would try hydrocortisone intravenously? Or you just ANC, which is you continue with the fluids, diuretics, hydrocorts, or all of them? So let's go back to the chat box and let's see what do you think. So IV hydrocort, IV bisphosphonate, continue IV hydration diuretics. Yeah, thank you very much. Perfect, good answers. The ANC, right. Okay. I'm not going to answer the question now. I'll come to the answer later on. So in the 3 cases that we just discussed, the alkaline phosphatase was the clearly abnormal marker in all of these 3 cases. So we have shown low alkaline phosphatase in the 3 cases. So when the alkaline phosphatase is low, that is called hypophosphatasia, HPP. So what is the HPP? The hypophosphatasia was first described by Rathbun in 1948. Therefore, this disease is also called Rathbun's disease. It was first described in a 2-month-old male infant. The clinical features sometimes can mimic rickets. However, they would have completely different biochemical changes. In rickets, for example, the clear demarcation is low phosphate. However, in these cases with HPP, usually they have a little bit elevated phosphate. In addition, the alkaline phosphatase in the HPP is usually low. It has to be low to get all these abnormal findings. While in rickets, usually the alkaline phosphatase will be elevated. However, the weakness of the bone resulting from the hypophosphatasia can cause deformities similar to the deformities that we see with the weakened bone by the rickets. So HPP, it's a rare genetic disorder characterized by the impaired mineralization of bone and teeth. And this bone disease is caused by an inactivation mutation of the ALPL gene, which encodes the tissue non-specific alkaline phosphatase. How common is this problem? Now, from Canadian studies, it affects the affected people are between almost 1 to every 2,500 people, and the carriers are 1 to 25. In the US, the affected are 1 to 100,000 population. In France and Northern Europe, the affected are 1 to every 300,000 population. In Japan, 1 to every 150,000 population. What about our region in the Middle East? Unfortunately, we don't have a clear prevalence from the MENA region, from Middle East and North Africa. Therefore, this is an invitation to researchers and colleagues from this area to work on this disease, identifying this disease. Perhaps we would have a higher prevalence in our region because of the consanguinity, but yet cases are missed and they are underdiagnosed. This is what I believe and I think. Right, let's go through this cartoon. In healthy bone, the alkaline phosphatase is important for building strong foundation. So let's assume this is the alkaline phosphatase. What happens is we have a component called pyrophosphate, the inorganic pyrophosphate PPI. Then this component goes through the alkaline phosphatase effects to result in dephosphorylation, and that will yield the inorganic phosphate. Okay, so that's the inorganic phosphate. Inorganic phosphate then will meet up with circulatory calcium. So the phosphate will couple and bind with the calcium, and that will result in formation of hydroxyapatite crystals. Now, the hydroxyapatite crystals are those components that gives the bone the strength. Without hydroxyapatite crystals, the bone will be weak and fragile. Okay, so that's what happens usually. So let's go back through it quickly again, because we need to understand this mechanism, because it will help us later on to understand the treatment. So we have the inorganic pyrophosphate go through the effect of alkaline phosphatase to be dephosphorylized. That will result in inorganic phosphate, and it meets with circulatory calcium. It binds with it, and that will result in the hydroxyapatite crystals, which gives the bone the strength. Okay, right. Now, in cases of hypophosphatasia, as we shown earlier on, the 3 cases, they have low alkaline phosphatase because a loss of function due to the mutation of the ALPL gene. So they would have reduced alkaline phosphatase enzyme activity. So that is not going to work. So basically, the inorganic PPI, pyrophosphate, will not get the effect of alkaline phosphatase to be dephosphorylized. Hence, therefore, a result of that will be accumulation of the PPI. That accumulation of PPI will have a toxic effect. On the same time, the circulatory calcium is not going to find the inorganic phosphate to couple with to formate the hydroxyapatite, which is going to give the bone a strength. So we'll end up here, elevated PPI, elevated calcium, and the alkaline phosphatase was the reason because it was low. I hope it's clear so far. Now, the alkaline phosphatase has got many other roles, and it expresses a number of tissues, such as liver, kidney, the deciduous teeth. So we have the paradoxal 5-phosphate, the PLP of vitamin B6, which is an important cofactor for a number of neurotransmitters. Unfortunately, this big component cannot cross into the cell and reaching the cytosol without the help of alkaline phosphatase. The PLP is big component, cannot go through the channels. So alkaline phosphatase is going to help by removing some of the phosphate to result in pyridoxal. And pyridoxal can pass through easily to the cells. And then it's a bit clever work in there. With the PL kinase, we'll get another phosphate again to form the PLP again inside the cell. Now, this PLP, vitamin B6, is very important for the nerve cells. It got lots of actions. One of the actions is to help phosphoethanolamine P-lyase enzyme to metabolize the phosphoethanolamine. Okay, so this is how it works. Now, if we have a defected the tissue non-specific alkaline phosphatase, what is going to happen? Those PLPs will not be able to break down to go through the steps that we just explained. Therefore, there will be accumulation of vitamin B6 outside the cell, not inside the cell. Therefore, it's not going to perform its mechanism of action on activating those enzymes to metabolize the phosphoethanolamine. That will result in high PLP in the circulation and high PEA, the phosphoethanolamine, either in the circulation or in the urine excretion. Now, in summary, the problem is because of the mutation that happened with the APL gene, we have low activity of alkaline phosphatase, resulted into elevated PPI, the inorganic pyrophosphate, and we got elevated vitamin B6, the PLP, and we have elevated PEA, right? So those are our markers that will help us in diagnose patients with hypophosphatasia. Remember, the alkaline phosphatase is the main problem resulted in all these defects. Now, what are the effects of elevated PPI and elevated vitamin B6 on the body, on the human body? So let's see what's happening. Let's start from the head to toe. So the effect of weakened bones that could give you abnormal shaped head, and sometimes there will be premature fusion of sutures resulting in craniosynostosis, and craniosynostosis could be leading cause for raised intracranial pressure. And because the cells, the neural cells, were deprived from vitamin B6, so those patients could seize and would have refractory seizures, not responding to the usual anti-epileptic medications. As a result of that deprived neural cells from vitamin B6, developmental delay is likely to happen. Okay, going down on the face, there is early non-traumatic teeth loss, and I'll show you some pictures. How does the tooth come out with the root completely? And that happens at an early, unexpected age. And because of the weakened bones, So that could lead to chest deformities. And that chest deformity, in addition to the effect of low alkaline phosphatase activity in the lung, so both causes hypoplastic lungs. And because we mentioned earlier, the calcium could be high, so that hypercalcemia will lead to hypercalciuria, and the hypercalciuria could lead to nephrocalcinosis, and nephrocalcinosis can lead to renal impairment. And because the bones are weak, the muscles are going to be weak as well because of low expression of alkaline phosphatase and low activity there. So that will cause hypotonia. And as a result of weakness in the bones and weakened bones and bone pain, the gait and the mobility will be affected. So usually those patients will have abnormal gait. In addition to this and that, it's not infrequent for those patients to have fractures, pseudofractures, and bone deformities. Okay. Sometimes people will get even exophthalmos, but this is a little bit rare. We should not forget that their growth will be affected, and they usually are short, or they are going to failure to thrive during their infancy. This photos from clinical case reports showing the falling teeth in a patient who is 2 years old. It's unexpected for a child 2 years old to lose the incisors, and you see that the tooth is coming out with the whole root as one piece. This is unusual, and this can be very suspicious for cases of hypophosphatasia. So if you work in the primary care level and you come across this case, when it came to your knowledge that a child who is younger than 6 years and start having falling of teeth, then you should raise a suspicion of hypophosphatasia, because that is unusual. Sometimes patients could have mild type of hypophosphatasia, so they wouldn't have any other deformities or fractures or anything, just the falling of the teeth prematurely without any trauma. And that's going to take us to the mildest form of hypophosphatasia, which is called odontic hypophosphatasia. Now, what are the types of hypophosphatasia that we have? So far, we have 6 types, and the classification is based on the age and the severity. This one is the very mild type, and this one is the very severe type. So severity is increasing. The odontohypophosphatasia is very mild type of hypophosphatasia. We don't expect lots of implications on the life of the patient. This is the adult hypophosphatasia, usually will have a mild course. Some of those patients might have fractures, pseudofractures. Perinatal benign hypophosphatasia here, and then we have a childhood hypophosphatasia, or otherwise called juvenile hypophosphatasia, from age of 6 months onward up to age of 18. And we have the infantile hypophosphatasia, and we have the perinatal hypophosphatasia. The perinatal hypophosphatasia is the worst. It can be lethal, and the mortality rate as well as the morbidity is very high. Those 2 types of hypophosphatasia are autosomal recessive, whereas the rest 4 can be autosomal recessive or dominant. Now, this is an X-ray of a patient with perinatal hypophosphatasia. You can see from this X-ray marked hypomineralization of all bones in the body, including the cranium, the vertebrae, and the long bones. You cannot see much of the bones there. Okay, and this baby had very narrow chest. That would definitely be associated with lung hypoplasia, and that led to respiratory distress, which is inevitable basically. These are x-rays for kids with hypophosphatasia. You can see the copper beaten skull appearance. Obviously, these patients had craniosynostosis as well. Look at this x-ray. Now, this x-ray shows the radius and ulna of this patient's right hand are showing some focal and irregular calcification with lots of lucency here. We do not normally see this in patients with rickets. Usually with rickets, we would see cupping and fraying, but look at this radiolucent tongue going there, and look at this. So it looks slightly different from the rickets X-rays, and this is the usual appearance in the bones. That doesn't mean they don't have rickety changes sometimes. They could do that. Look at these X-rays. They could have something called Bowdler spurs, and this patient got it bilaterally. You see that? Let me use the marker, perhaps it's going to be, look at this. This is the spur called Bowdler spur. It happens on both sides, and this patient with hypophosphatasia as well. Now, going through the cases that we described earlier and going through the mechanism, perhaps we think it's very easy to diagnose because majority of these patients will have low alkaline phosphatase and other biochemical markers. So why the diagnosis is always and often delayed? Number one, we think because of lack of awareness. Not many people that are aware of the HPP. That's one of the possible reasons. The other possible reason is because of the mild type picture of disease. So it can have mild symptoms similar to the odontic type. And sometimes the feature can overlap with other disorders, as we mentioned, rickets, because of the weakness of the bone and the deformities. Dr. Graisman worked on 9 centers in Germany, and they did cross-sectional analysis for all patients, pediatric patients, having low alkaline phosphatase. Dr. Graisman stated that low readings of alkaline phosphatase are not always recognized in clinical routine. Majority of the healthcare professionals will omit the alkaline phosphatase and the low alkaline phosphatase, and they will not pay much of attention to it. Majority of the healthcare professionals and physicians, they usually get interested more with elevated alkaline phosphatase, not the other way around. So in 9 centers in Germany, they excluded the patients with intensive care whom had, or the other patients who had oncological or hematological disorders, or the other patients who had normal level of alkaline phosphatase in the past. And the results of that study, they found out of 370 children fulfilled the criteria, 15 of them, which is 4.1%, having a diagnosis of hypophosphatasia. And this is a recent study, August 2021. Now, the other patients whom did not have hypophosphatasia, but they had low alkaline phosphatase, they found among them, the majority are having either hypothyroidism, almost 12% of them, or they had exposed to steroids, or they had malnutrition, anorexia, for example, or they had estrogen or other medication administered, or severe illness, or deficiencies in vitamins such as vitamin B12, C, and D, or they had growth hormone deficiency. Some of them had anemia, celiac disease, magnesium deficiency, abnormal parathyroid hormone levels. So a question mark can be raised here. This recent study from 9 centers in Germany revealed this. What about our centers? Have we looked into the investigations that showed low alkaline phosphatase to find out how many of those actually are having possibly hypophosphatasia undiagnosed, and how many of them having these different pathologies? I think this may worth to be studied in our centers. In a survey was conducted in the UK among 26 laboratories, the lower limit was not based on age and gender, and that was found in 8 labs. There was no gender-specific reference rate. And in 2 labs, they put the lower limit as low as 0. So any alkaline phosphatase will not be flagged by the lab system because the lower limit, they put 0 U per unit per liter. And these 2 labs out of 26, so 10% of the labs would not discover or flag the low alkaline phosphatase for those patients. Okay, and in that survey, they conclude there is often a lack of recognition that pediatric reference rates are significantly higher than adult ranges. Okay, so Colantonio and colleagues in Canada worked on 40 biochemical markers in a healthy and multi-ethnic population of children. And their study, their extensive study, wonderful study, showed us the different alkaline phosphatase levels according to the gender and according to the age. So in 0 to 14 days old babies, they will have the lower limit of their alkaline phosphatase is 90. When they are 15 days old up to 1 year of age, the alkaline phosphatase will be higher. So the lower limit is 134 and the upper limit is 518 as the child is growing in these years. So the alkaline phosphatase, the turnover of the bone cells will be higher, which means the lower limit is going to be high compared to when they are going through their puberty and reaching the adulthood. So the adulthood cutoff, the lower limit is 40, whereas in 1 to 10-year-old female child, the lower limit is 156. And this different from between boys and girls. So for example, in this one, it was for the age 13 to 15, the lower limit is 127 for males, but 62 in females. So it's very important that we pay attention to the reference range. Some of the labs, as we shown earlier, they put a reference value for adults, not for pediatrics. And some other labs, they put a pediatric reference ranges, but without taking in consideration the gender. As the survey from the UK showed, 8 labs out of 26, so that's almost a third of the labs, they don't use the gender-based reference values. So it's very important now to make a proper diagnosis. You need to know whether the reference values are used correctly or not. This lab results showed anything below 500 is normal. So for a patient with alkaline phosphatase 32, it's not going to be flagged on their system. You see? Now, we discussed these reasons why the diagnosis is delayed. And now we concluded that sometimes there will be overlooking of low alkaline phosphatase. So physicians are more familiar with high alkaline phosphatase, not the low alkaline phosphatase, or they are not using the appropriate age gender values, or their labs are not flagging up. Now, let's see that study from Colantonio resulted in having this app. And this app is actually very helpful. Let me just take this off. So if you go on your app store, or if you have Android, you put Caliper on the store, on the applications, and then the Caliper that will appear, when you download it, you put the test that you want to have, say, for example, alkaline phosphatase, and you put the values that you are having from the investigation, from the test that you've done, and you select the gender, and you select the age. And then you click on evaluate. It will tell you. So for example, this patient, the level was 125. So it tells you the patient results fall outside. If we change this value, say for example that this patient has got alkaline phosphatase of 225, it tells you that the level is 225, which is falling within normal range for this age and gender, between 141 to 460. So it's very useful app if you want to use it. It's free, you don't have to pay anything for it, and you can use it for other biochemical markers. Okay, right. If we go back to this case and we ask about what is the most likely diagnosis, the first case, the diagnosis was hypophosphatasia because the alkaline phosphatase was 55 for a patient who is only 7 years old. And if you go for female, 7 years old, this patient should have at least 156 as a lower value. So this patient had hypophosphatasia confirmed later on by genetic testing. And if we go through this case where the patient had hypercalcemia, then the treatment with hypercalcemia, we should not use IV bisphosphonate in those cases. It's actually contraindicated and it has to be avoided. And the reasons behind that, bisphosphonate can mimic the effect of PPI, the inorganic pyrophosphate. Okay, and the inorganic biphosphate itself, it inhibits the mineralization. Now, if you don't have the alkaline phosphatase activity, so there will be accumulation of more PPI. That's from one side. In addition, that the bisphosphonate will prevent further mineralization and may cause worsening actually of the case. And some patients will end up having fractures, and that is evidence-based, will end up having fractures after receiving bisphosphonate. So the ideal situation is to give hydration and be careful with diuretics, because those patients with hypercalcemia, and they already having hypercalciuria, and perhaps they already have an established nephrocalcinosis. So if you give further diuretics, you may precipitate more problem with the nephrocalcinosis. So just be careful with that. Okay, sometimes you need to give it, it's fine, but just be careful with the monitoring what's going to happen. It's important to involve dietitian in those cases to give a low calcium milk or low calcium diet to reduce the amount of calcium going in. Okay, IV hydrocortisone, it can be tried in such situations. However, calcitonin has been used and showed some effect. Okay, these are the treatment, available treatment if you don't have the most recent and the appropriate treatment for this disease. We'll come to that in a couple of minutes. Now, there is a guidance on how to diagnose the hypophosphatasia. We talked about low alkaline phosphatase. If you have these kind of skeletal or muscular or dental features that we mentioned earlier during the mentioning the clinical feature of the disease, plus minus respiratory symptoms, neurological symptoms, rheumatology in terms of pain, joint pain, or renal involvement because of the hypercalciuria, or metabolic because of hypercalcemia and hyperphosphatemia, or delayed growth, then you should raise your suspicion of HPP. Then you need to assess the activity of alkaline phosphatase. If it is lowered, so low alkaline phosphatase, in absence of other causes that causing low alkaline phosphatase, then perhaps you can proceed to confirm by measuring the PLP and PEA. If they are elevated, then you could have a clear diagnosis here. It's not necessary that you confirm it with the genetic testing. However, the Japanese Pediatric Endocrinology Society, they considered it's recommended that you do the genetic testing, especially if you're going to start the hypophosfatase, which is the treatment that we're going to talk, the enzyme therapy. And this was done by a group of clever scientists, and that was published 2018. I found this also very useful way from biochemical point of view, was written by Prof. Fraser from Norwich in the UK. Now, if you have low alkaline phosphatase, you need basically to review the medical history for low alkaline phosphatase and make sure the sample has been sent in the right bottle, because sometimes artifact could lead to low alkaline phosphatase if the sample was sent in an EDTA bottle or an oxalate bottle. Then you check for the metals or vitamins. So if the patient is having low zinc or magnesium or high copper, like in Wilson disease, those could contribute to low alkaline phosphatase. So in such case, you need to treat the abnormality here, and the alkaline phosphatase will be normalizing. If the patient has got malnutrition, that will be reflected on low level of protein and albumin. That could be a reason for low alkaline phosphatase. If the patient has got hormonal disorder like hypothyroidism or hypoparathyroidism or severe anemia, that could be a reason for low alkaline phosphatase. Therefore, you need to measure these markers. If the patient has symptoms suggestive of vitamin deficiency, such vitamin C, scurvy, or B12, pernicious anemia, or folate, or the patient was giving excessive amount of vitamin D, so he was intoxicated with vitamin D, that will lead to suppression of alkaline phosphatase, and that would be a reason for low alkaline phosphatase. If the patient who underwent a major surgery, or if the patient receiving medications such as bisphosphonate or fibrate, that could be a leading cause of low alkaline phosphatase. So it's important to rule out the other causes. Look in the history, you might find an answer, and that will help you to reach a diagnosis of HPP. The Japanese cohort of pediatric endocrinologists came up with a clinical practice guideline for hypophosphatasia published in 2020, and it's of use to go through. There is an emphasis on dealing with these cases on multidisciplinary team approach. And that will include pediatricians, whether endocrinologists, intensivists, pulmonologists, as we've seen from previous cases, surgeons, orthopedic surgeons, neurosurgical surgeons for the craniosynostosis management, ENT, sometimes they need to be involved, physiotherapists, occupational therapists, of course, dentists and geneticists, radiologists. So you could see you need the multidisciplinary approach to manage those patients appropriately. Luckily, in 2012, that was the first reveal on the Strensiq, the hypophosphatase, which is a treatment for this sophisticated disease that has got a huge burden on the quality of life of affected patients. It's an enzyme replacement therapy for hypophosphatasia. And this enzyme therapy, basically, it just mimic the effect of alkaline phosphatase. So it is alkaline phosphatase replacement. So what happens is the inorganic pyrophosphate will go through the effect of this enzyme. It will get resulting in inorganic phosphate, which is going to couple with the calcium to result in hydroxyapatite, which will help the bone to be well formed and is going to prevent all those complications, most of those complications that we mentioned earlier. And of course, has proven over the last few years the impact on marked improvement of morbidity and mortality for patients with hypophosphatasia. Now, the indication for this treatment is indicated for treatment of patients with perinatal or infantile as well as juvenile hypophosphatasia. Now, I'll take you through this video for a patient who was treated with this enzyme therapy, and I'll leave you to see the improvement. This is as baseline, this is gait. You can see he's walking with some difficulty, and his gait is a little bit slow. So as he was receiving the Strensiq, this is after 3 months. Perhaps it's early to see dramatic improvement, but some improvements start to show off. This is after 6 months. You can see he's walking quicker than he used to be. And this is after 9 months. And after a year, you can see the gait is much improved. The quality of the walk is much improved. The distance that he's spending in a 6-minute time is much better than he used to be. So the treatment it's fascinating. Now, take-home messages. Hypophosphatasia is easy to diagnose, but sometimes is missed if we are not aware of the disease. Remember the low alkaline phosphatase, and remember what we've discussed today about making sure that you have the appropriate reference values based on the gender and age. The untreated hypophosphatasia can increase the risk of morbidity and mortality. Vitamin D and bisphosphonate both to be avoided in hypophosphatasia. Vitamin B6 can treat convulsions in hypophosphatasia. And recombinant tissue non-specific alkaline phosphatase is the treatment choice for hypophosphatasia. Don't feel that you are left alone. We are always at the other end of the phone. If you have any suspected case, please pick up the phone and speak to us. Any of the pediatric endocrinologists and tertiary centers, they would be happy to help. Don't climb and take the burden on yourself. There are always people around you to help. And by this, I thank you again for your attention, and I'm happy to take your questions.
Thank you very much, Dr. Hussein, for this extensive and excellent talk. We have several questions in the Q&A section. The first question from Dr. Sumaya. She's saying that if alkaline phosphatase is needed to cross vitamin B6 intracellularly, so why refractory fit respond to vitamin B6? Ideally, they shall not cross the cell too.
Very good question, very clever question. Let me take you to the cartoon again. Don't mind. Thank you, Dr. Sumaya, for your question. So I think we are here. So this is the vitamin B6, and as we said, as a component will not be able to cross. Now the treatment is the alkaline phosphatase that was functioning before was dephosphorylizing this PLP, and therefore that was resulting in paradoxal. The paradoxal will find no problem to pass. Therefore, the treatment that we give, the paradoxin, is similar to the paradoxal. So it will pass through, and then inside the cell will get a phosphate with the effect of the PL kinase, and that will form the PLP again. So the treatment that we are giving as paradoxin is basically without a phosphate. So that will go through easily, and the coupling of phosphate will happen inside the cell. Therefore, PLP will get inside the cell. Therefore, that will stop the fit for those patients. I hope I answered your question.
Yes, it's very clear. The next question is from Dr. Iman. How to diagnose transient hypophosphatasia of neonate?
Again, so basically, a family history and the bone profile that you do, you check the alkaline phosphatase. So if you have low alkaline phosphatase and no other features, no family history, and the child otherwise appearing healthy, so you just need to monitor. If there is a suspicion of ongoing disorder, bone disorder, then you would carry on with your investigation that we've shown earlier. And if you find abnormality, then perhaps you're not dealing with transient hypophosphatasia. So monitoring in such cases are very important, and bringing those patients for follow-up to see what happens is important to miss those cases.
All right. There are some more questions from Dr. Sumaya. How hydrocortisone helps in reducing calcium in these kids?
So the hydrocortisone has no direct role on these cases. However, its indirect effect on the kidney, basically, trying to help with preserving the nephrons and the calcium loss through the urine. That is the mechanism that I'm aware of, by reducing the inflammatory process, as well as reducing the formation of active vitamin D. So by that, we'll reduce the further reabsorption of calcium from the intestine and from the kidneys, therefore less burden on the calcium, the hypercalcemia. But there's no direct effect on the alkaline phosphatase mechanism. That is why I said earlier that it can be used and has been used. Dr. Abdelhadi Habib tried it on one of his patients. But for example, the Japanese Pediatric Endocrinology Society, on their guideline 2020, they didn't put the hydrocortisone on the list of medication to be used for hypercalcemia. So they started mentioning about the diet control with low calcium diet. They mentioned the diuretics. They mentioned the calcitonin. Of course, if you have access to the aspartase, the enzyme therapy, that itself is going to be the treatment option for the hypercalcemia. That will bring the calcium down if you give the alkaline phosphatase as enzyme therapy.
Right. Some more questions from Dr. Sumaya as well. What is the long-term management of hypercalcemia?
Yeah, as I mentioned, this is a challenging issue. Therefore, for those patients, the dietitian should have a role. Low calcium milk initially during the infancy, and low calcium diet later on. Vitamin D should be avoided in those patients unless the patient is having vitamin D deficiency, for which you would give a corrective dose to bring those vitamin D levels up to normal, and then you just be careful. You don't want it to be above normal, and then you stop the course of treatment. The sun exposure is allowed as usual, as everyone else. Hypercalcemia should be, hypervitaminosis should be avoided, as well as bisphosphonate usage. So mainly diet, and you can use diuretics, short courses of diuretics. As we said, be careful with the furosemide because it can worsen nephrocalcinosis, and that could precipitate the chronic renal disease. Calcitonin can be used in certain conditions when the calcium is very high, but that's not for the long run.
All right. Some more questions. Does all cases of hypophosphatasia need strensic?
As we said earlier, the indication was for the infantile, juvenile, and perinatal hypophosphatasia. Is not indicated for odontic, for example, is not directly indicated for adult hypophosphatasia.
And continuing in that question, what is the age to start it, and how to monitor while on treatment?
You can start it as soon as you make a diagnosis. The younger age you can start with, especially for those patients with the perinatal and infantile, because we said due to the severity of the disease, you need to start early on with treatment to prevent all the deformities that could happen which lead to worsening of the condition. And
Yes.
the impact of that has been reflected on the improvement of survival in those patients. So the aspartame has increased survival rate from 27% to 84% in patients in a 5 years treatment, the first 5 years of treatment, especially for those who require ventilation. So the numbers I have here, from 5% to 76% survival. And those patients with the vitamin B6 dependent seizures, especially the infant, increase the survival from 0% to 77%. So yes, you can start with that as early as you make a diagnosis. And what to monitor while on treatment? Very good question. So the monitoring, to monitor the efficacy of this alkaline phosphatase enzyme, you check the clinical progress and as well as the radiological changes. So you will take baseline X-rays and you compare it later on as the treatment is going on. Usually the RSS score will show improvement, and you can go by the clinical kind of achievement as well. How is that reflecting on the symptoms of the child?
All right, thank you. Another question is in resource limited countries with no access to enzyme therapy, what is the alternative?
We need to work hard perhaps to get this enzyme replacement therapy because lives of people matters. So perhaps negotiations need to take place with the company, with the health authorities, with charities. So we need to work on that because as we mentioned earlier, the mortality rates for those, especially those patients with the infantile and perinatal, is very high. And unfortunately, lots of kids had lost their lives in the past. But when the medicine, such a wonderful medicine, came to the light and the people start using it, the mortality has reduced dramatically. Without having this medicine, unfortunately, there is no treatment for that. You just treat the you treat the symptoms perhaps, and you give supportive treatment, and you try to reduce the complication as much as you can. But you're not going to prevent them from happening because the bones are going to continue to be weak and deformed, and they're going to fracture, and those patients will, as we mentioned, the complications of the disease and the burden on their life. So unfortunately, there is no alternative.
Yeah. Thank you so much. There is another question. Does the enzyme replacement helps in attaining height too?
Yes, certainly, and that was evidence-based as well. So for patients who receive aspartame for 5 to 7 years, that some studies showing good response, and the height is increasing for them. Yes, because the bone health is improving, and since the bone health is improving, the elongation of the long bones will happen.
Right, and she's asking about the trial of growth hormone in those patients.
I'm not aware of any, and I don't think there is a reason for that to take place. If we have a deformed bone and you give growth hormone for that, perhaps you're going to worsen the problem and causing more deformities to those deformed bones, if not fractures as well. The growth hormone, if there is evidence of growth hormone deficiency in those patients, certainly you need a solid bone to work on. But as I mentioned, from the studies that took place for patients who received aspartame, their growth parameters improved without treatment, without the need for growth hormone.
Yeah, crystal clear. There's one more last question. Is fetal ultrasound recommended for early diagnosis or prognostic improvement of hypophosphatasia?
Fetal ultrasound, of course, yes. If you detect the problem early, you would put plan early So early detection means early treatment, and early treatment means appropriate treatment as well to avoid worsening of the clinical outcomes. So that is strongly recommended because that will result in better quality of life. It's better than going without knowing what's happening, and then you face a problem and then you start planning afterwards. So starting from the time while antenatally, that will certainly help to find out if there is evidence of skeletal dysplasia on those antenatal scans to get yourself prepared. So it is very important, yes.
I think we have cleared all the questions. If there is no more questions, we will end up this talk.
Okay.
Anybody want to add anything or questions before we close?
Thank you very much for having me tonight, and I hope that we have contributed to increasing and raising the awareness of hypophosphatasia. And as usual, I'll be happy to take any kind of consultations about this. And I think there is an evaluation form here to be filled quickly, if you don't mind. And thank you again for attending this session. See you soon, and goodbye.
Thank you so much, Dr. Hussain, for this.